Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Happy and blessed Ramadan. May Allah accept your fasting and good deeds. Dr. Mohammed Alsheef, your host of Elixir of Life, is kicking off another inspiring and informative episode with our distinguished guest, aiming to explore new frontiers and bring you most up-to-date information related to health. Our program is filled with many stimulating segments. Most importantly, our episode theme, shoulder problems, with our distinguished guest, Dr. Hassan Sawan. Stay tuned for a special episode. Once again, welcome back to Elixir of Life. Our next segment, our topic of this week, shoulder problems. Shoulder joint is the most mobile and movable joint in the body. It is the most potentially unstable joint, hence it is a common site for problems, including trauma, dislocation, rotator cuff, tendonitis, bursitis, tear, and many other problems. To know more details about the shoulder problem, like symptoms, diagnostic method, state-of-art therapy and research, it's my immense pleasure and honor to present my distinguished guest, Dr. Hassan Sawan. He's a consultant orthopedic, and he is upper extremity and orthopedic oncology surgeon and chairperson of surgical specialties department at King Fahd Medical City. Welcome, Dr. Hassan.
Thank you. Thank you. Thank you for having me.
Happy Ramadan. Okay.
Thank you.
Okay, without further ado, we'll start our very interesting topic. We have very interesting agenda. Starting by, what's the structure of this joint or shoulder joint?
So the shoulder joint is a very complex joint from anatomical point of view. There is a lot of bony structure and muscles and tendon passing by, a lot of important nerve and vessels. So let's start by discussing the bones itself. So the shoulder joint is composed of three main joints. It's the collarbone. We have it, the clavicle. Okay. Then we have the shoulder blade.
Can we zoom? Yes. Okay.
The clavicle. Then the shoulder blade.
So what you mentioned again, the important components, the bones, muscles,
joints, and
tendons.
Muscles and tendons. Yes.
So we're starting by the the bone. Yes, go ahead.
So the bone, collarbone, as we said, the clavicle. The shoulder blade is the scapula, and
can we zoom to that one, please? Okay.
So we have here the clavicle again, shoulder blade or the scapula, then the proximal humerus. So all the shoulders are connected to the trunk by 9 muscles. So 3 in the front, 5 in the back, and 1 on the side. Those muscles connect the trunk or the body to the all extremity. So this is the importance of it. Then we have the thoraco-scapular joint. This is the first joint.
Sure.
Then 3 joints that cause a lot of problems in the shoulder itself and can cause pain, arthritis, and all of this. So the sternoclavicular joint is the joint between the clavicle and the sternum, the chest bone.
Yes.
Then we have the acromioclavicular joint that's connecting the shoulder blade to the clavicle again, the collarbone. Then the glenohumeral joint, or the shoulder joint itself, the anatomical joint. So this is the joint that connects the shoulder blade to the arm itself, the arm bone. As we said, a lot of muscles connect. One of the most important muscle and interesting muscles is the rotator cuff. Rotator cuff, we can summarize the cuff by it's 4 muscles. So if we see this anatomical model, so we have it's by name. So this is subscap muscle.
Can we zoom more, please, to that one? Right.
So this is the subscapularis muscle. This is
Excellent.
the supraspinatus. In the back, we have the infraspinatus and teres minor. So why it's called the rotator cuff? It's called the rotator cuff because it's rotating around the shoulders, covering it completely, the shoulder joint, and its function as the initial movement and the stabilizer of the shoulder joint inside the socket. So the big muscles can, the big muscles can act on the shoulder blade smoothly. So the function of the shoulder blade and the biomechanics is important.
Yeah, that's very important. What makes it different from other joints? Okay, that's very important.
So yes, so when you have a lot of structure involved in the same anatomical area, you need harmony between all of them. So all of this structure need to move together, not to cause any disharmony or
synergistic. Huh?
Yes, that's it. So when you have the shoulder blade moving, at the same time the humerus is moving, so to make the movement together. Okay, so all of this is moving together and need to move in harmony. When something is not moving properly, or you have a problem in one of the mechanism, shoulder pain happen, and all the other structure become overloaded and become more weak, so you have more shoulder pain.
Very interesting, Dr. Hassan, that the structure, the complex structure, that you made it easy, and the biomechanics of this joint. Yeah. Because let's compare to the other joint, like the hip joint. What's different from the, in terms of mobility, okay?
So if you notice that the shoulder joint have a very flat bone here. Mm-hmm. So it's a very flat, it's not a socket, actually it's a very flat bone with a huge, they compare it to the golf ball on the small thing that you kick, the golf ball. I'm not sure what's the name, but so it's a very mobile joint. It can move 180 degrees all over, with the help of course of this shoulder blade
degrees, okay.
Everywhere, and especially to be accurate, it's limited only by some like structure inside the joint, ligaments, for the movement. So it's not a bony constrained joint.
Excellent.
Like the hip. Yes.
Very, very interesting.
Yeah.
Dr. Hassan, just understand from your introduction that you are sub-specialized in upper extremity. Is it sub-specialty of orthopedic surgery?
So yes, a lot of people are sub-specialized now in upper extremity surgery. This involves shoulder, elbow, and wrist and hand diseases. So we do the sport injuries, we do the arthroplasties of the upper extremity, the nerve transfers, and we are more sub-specialized in this area, anatomical area.
So this is different from sports injury?
It is different, yes.
But there is overlap?
There is overlap, of course. There is a lot of great shoulder surgeons that are sport medicine guys, and vice versa.
Very interesting. How many years this training require?
It's usually fellowship after your residency, so it's a 1 year training after residency, yes.
And I understand from this is rare subspecialty in Saudi Arabia.
It is rare, but a lot of my colleagues are coming back now, and it's becoming more and more popular and more advanced in
Excellent.
Saudi Arabia. Yeah.
Great. Dr. Hassan, from your vast experience in this field, what are the common shoulder problems you face in your clinic or daily clinical practice?
So we can broadly divide the patient complaint to two types. So either the patient will have pain, and this is the most common things, or instability. So he's complaining of unstable joint. Going more to details, so causes of shoulder pain there is a lot. We can divide it mainly to actually an external cause of shoulder pain, that the patient feel the pain in the shoulder, but actually the pain generator is not inside the shoulder. And structural problems that causing shoulder pain, that it is in the shoulder region. Instability is usually, we can divide it in traumatic or atraumatic. This is the broad description.
Excellent. Great. Dr. Hassan, the pain is the most common presenting complaint.
Yes.
How do we differentiate between a pain that is mechanical versus inflammatory pain, like arthritis from rheumatoid or something? So
let's go more in specifics about the pain. So pain in the shoulder area usually it's by actually listening carefully to the patient
History,
complaint,
yes.
knowing exactly when does the pain happen, how does it happen, what's the aggravating factor, what's the relieving factor, does it increase with sleep or overhead activities, any triggering things that trigger the pain, any habits that the patient have, any job that can cause load on the shoulder joint itself that can cause this pain. By this, usually we have like a rough idea where is the pain coming from. Is it really come from the shoulder or from the outside the shoulder? Then we dig more with the patient about his ability to move, examine him carefully, and by the end of the clinical session, usually we have a rough diagnosis that we can confirm more with using some investigations.
Excellent, excellent indeed, Dr. Hassan. What are the common causes of shoulder pain that you encounter?
So we face, let's divide the shoulder pain generators to either it's coming from the muscles.
So you want to
from the rotator cuff, as we spoke about it, the rotator cuff joint itself, or a very common pain generator is the biceps tendon. Actually, the long head of the biceps is coming from outside the joint to inside the joint. So it is one of the causes of pain, especially in athletes and overhead throwers and all of this. It does cause some pain. So this is the most important thing in muscles. We go to the also to the joints itself. So arthritis of the shoulder joint, of the glenohumeral joint itself, in the sternoclavicular joint, or the AC or the acromioclavicular joint can cause pain. Any inflammation. Inflammation can be due to like degenerative changes, aging by itself, or by rheumatological disease like rheumatoid arthritis and that's structures. Okay.
That's important. And what are the common diagnostic methods besides, as you mentioned, important history taking and physical examination?
So usually every patient that complain of shoulder pain should at least get 2 views of the shoulder. Make sure that we're not missing any structural lesions causing the pain, causing the discomfort. Then other modalities will be ultrasound. Very useful, but not very specific. It is dependent on the operator himself. You need some expertise. Some orthopedic surgeons are actually do this as a bedside in the clinic if they have the facility. Then next step is the MRI. MRI is the most common, requested investigation for shoulder problems because it diagnoses a lot of shoulder problems and it shows the anatomy very clearly to the surgeon so he can decide what kind of help he can give to the patient.
So why MRI, let's say, more useful than CT? Is it good to show the structures beside the bone like ligament, tendon and muscle?
Of course, everything has its indication. So CT scan will be useful in more arthritic disease, in operative planning for as a surgeon.
Excellent.
CT scan have advanced techniques about subtractions and 3D reconstruction, so we see really the bony anatomy very clearly. MRIs will show more the ligaments and the tendons, the capsule, the soft tissue things that usually CT scan doesn't pick up.
So I'm I'm internist. Okay, if I have a patient with shoulder pain, after taking history and physical examination, before I refer the patient to you as orthopedic, you recommend me to go for MRI.
I don't recommend using MRI a lot.
Sure. Because
of its expense and the load and the burden on the health system. So if the patient really have some pain, like I think as a general practitioner, everybody should know at least basic symptoms and signs and how to treat them. Most of the shoulder surgeries are conservative management and need some physiotherapy, some education about patient habits, and he will improve. So at least X-ray will be enough as a GP.
Excellent.
If the GP is very confident about his exam and his way of knowing about the shoulder symptoms, he can request an MRI. but it shouldn't be a routine thing.
Excellent. So just utilize the resources
What you have,
effectively
yes.
and cost-effective to practice cost-effective medicine.
Yes.
That is not, shouldn't be always. It should be based on the history and physical examination and duration of the pain.
I agree with you.
Excellent. Now we are going, we need to know, how should I know about specific shoulder problems? We will dissect them one by one, starting by dislocation, about the cause, symptoms of dislocation and management, okay?
So dislocations, as we said, we can, let's concentrate on the most common. It's traumatic dislocation.
So we can show the dislocation, how does it
So
show in this
dislocation, we can divide it by the anatomical dislocation. Where does the shoulder go?
Yes.
So usually either it's anterior.
So what does it mean simply, the dislocation? I mean,
so dislocation is separation of the joint. So the joint surfaces are not connected anymore together.
Excellent,
so
great.
If the humerus disconnect from the glenoid or it's not in contact,
okay,
this is dislocation.
So if the ball is not inside the socket,
that's it basically.
Yes.
There is a lesser degree subluxation. Everybody know about it. That it does move a little bit, but it still have some contact with it.
Excellent.
So dislocation can be divided, as you said, as a cause, so either traumatic or non-traumatic, or as a direction. So either it's anterior dislocation, so when the shoulder go anterior to the shoulder blade.
Excellent.
Or when the ball go to the back.
Posterior.
Posterior dislocation. What's the most common? The most common is anterior. It's traumatic. Usually happen in the overhead throwers or in a movement that the patient is doing like this exactly. So when he's doing like this. So he's pushing his arm to the back and the shoulder is coming out in the front.
So what kind of sports usually they have this
So
one?
volleyball is the most common thing. Fall during a sport like a football can happen. Some patients describe getting something from the back of the car during the accident. So this is the most common thing.
Hitting from the back? It's
hitting, yeah, when his hand is in the back, so it's this movement.
Very interesting.
Posterior shoulder dislocation is most common, surprisingly, in patient with like seizure disorder or epilepsy. Patient that lose consciousness. It happened in diabetic patients. It happened when patients lose consciousness and have episode of convulsions. It happened because of the muscle balance of the shoulders, that the muscles that pushing the shoulder posteriorly is more powerful, so the dislocation happened posteriorly.
Very interesting.
Very yeah.
And management?
Management wise, so first dislocation usually doesn't need management if there is no fracture involved with it. So if it's only soft tissue injury, imagine the shoulder coming out of the socket, so all of the muscle and ligament will be injured. Muscle injury need to be treated surgically, but if it's only ligaments, usually we give a chance for the body to take to heal itself. Conservative management, followed by physiotherapy and regaining the power of the muscles. But there is exceptions always for everything. And first thing, of course, patient need to be reduced in the emergency room.
Is it painful?
It is painful, yes, but most of our hospitals now are equipped with conscious sedation. They give patient good pain control before doing it. There is a lot of described maneuver to reduce it, and doesn't have to be even orthopedic surgeon or colleagues in emergency medicine are expert in this also. So
excellent.
It's becoming more common thing to done. Yes.
So it doesn't require general anesthesia, only conscious
only sedation. Only sedation. Some people do it even with injection inside the joint, so a relief of pain. But any sort of good pain control will be sufficient.
Then after that, do they need any supplement or any cast?
Only like a collar or something to hang the arm in, only for resting and pain control. After that, according to the patient and the injury itself, we tailor the treatment for the patient need.
Yeah. Very, very interesting and beautiful. Now we are moving on to the second common shoulder problem, rotator cuff. Rotator cuff disease, tendinitis and bursitis.
Sure. So as we said, the shoulder joint itself have a lot of muscles inside, around it, and in it to move normally. So we have small muscles, as we said. Small muscles of the or rotator cuff. The most commonly used name is subscap, as we said, in front, supraspinatus, infraspinatus, and teres minor. All of this is rotator cuff, we call it. Okay. It functions for it move the joint and also stabilize the joint inside. So when the big muscles move, it move very easily. We need also for the rotator cuff to function normally and the shoulder to be, to be harmonious in the movement. You need the shoulder blade also to move with it. Half of the shoulder, a lot of degree of the shoulder movement come from the shoulder blade. The other come from the humerus itself. So you need both to work together. Rotator cuff problems is the most common pain generator in the shoulder joint. So any tendon can have a lot of things that can happen to it. So ranging from inflammation like tendinitis, from degenerative decay with aging, so degenerative tears, acute tear by injury, as we said, during dislocation sometimes the cuff become injured. Injury by itself can cause tear, and calcific tendinitis is another condition that can cause pain in the rotator cuff. That's it in summary.
And bursitis is
bursitis is bursa is something that is covering the shoulder to lubricate it and make it move in a easy way. So as you said, if you notice that there is a space here between the humeral head and the shoulder blade. This space is filled with bursa. So when the movement happen, it does happen easily without friction, without. This is God created it. So this space can happen, can have inflammation. Is it related to the degeneration itself? Is it related to inflammatory disease? Is it related to infection? It happened. Yes.
Very interesting, but it's less common than tendinitis, as you mentioned. The bursitis.
No, bursitis can be they are sometimes the same terminology. So,
okay.
So bursitis overlap. There's a lot of overlap.
Excellent. Yes. So what's treatment for rotator cuff disease?
So rotator cuff disease, we have to know exactly what the patient complaining from. Is it related to something he's doing that is triggering his pain and increasing the inflammation? So we start basically, as we said before, asking the patient, listening to him carefully and knowing what's his complaint. Examine him carefully. Then by the end of the physical examination, usually you have an idea, is the rotator cuff intact or not? So most surgeons don't need an MRI to diagnose for the material by itself. So we know by the end of the exam, most of us. Based on the exam, we direct the patient. So if it's only inflammation and tendinitis or impingement, physiotherapy will be most of the time enough. Of course, we have to take in consideration the patient age. It does make a big difference in the treatment. Then we go down to the tear. So if there is a tear, we diagnose it or confirm our suspicious with an MRI.
Excellent.
MRI will tell us, is it a partial, is it a full thickness tear? How big is it? How old is it even? Because of when the tear become old, fatty degeneration happen in the muscle, so we know it's old. And there is a different treatment modalities for every one of them.
But not surgical, okay?
There is, as I said to you, we tailor to the patient complaint and patient age especially. Most traumatic tears will be treated surgically.
Surgically, yes.
Most degenerative tears, especially in old population, conservative because of the nature of the disease, not because of the age of the patient. So how successful is to repair a very degenerated tendon? There is a debate, a large debate. There is schools that do surgery for most of the people. There's schools that are more conservative, but most of the people agree that degenerative tears repair by itself is not a good solution for it, but it does relieve the pain.
Excellent.
It does relieve the pain, yes.
As you have pointed out, the most common is pain in rotator cuff disease. What about limitation, the range of movement? Is it really, there is a clue by examination that this is most likely rotator cuff or...
Yes, yes. So Two symptoms of limitation of movement. There's two main pathologies with the rotator cuff. So
Excellent.
either the patient cannot move his hand above his head, and this is due to the injury by itself.
Yeah, so up to...
So he have limitation of this movement.
Okay, so this is...
This is either impingement, so the patient is feeling pain, this is why he cannot move.
Sure.
Or the muscle itself is torn, and this movement cannot happen.
Excellent.
Okay, so this is one. Another pathology that can mask all of this is frozen shoulder.
Excellent, that's what we can discuss
Yes,
later on.
and we can discuss it later. Yeah,
Sure.
as we said.
Now we are coming to the shoulder, frozen shoulder or adhesive capsulitis.
Yeah, sure.
Would like you to enlighten us about its causes and symptoms and treatment.
So for the shoulder to move freely, it needs a good space between the two joints, good lubrication, and enough of soft tissue slack, so it can move actually.
Mm-hmm.
If it's so tight, the capsule, it will not move.
Mm-hmm.
So, and this is the frozen shoulder. Frozen shoulder, what will happen is thickness of the capsule itself, due to some people have causes, some people doesn't have causes, that limit the movement of the joint itself.
Mm.
And a lot of people say, stiff joint is a painful joint.
Mm-hmm.
By definition.
By definition,
Yes.
excellent. And the treatment or management?
So management, frozen shoulder is self-limiting disease. So if we waited on the patient, the disease will cure itself at one point. When is the point? Nobody knows.
Self-limited disease.
Self-limiting disease, yes. It doesn't progress. But it is limiting to the patient because of the pain and the restriction of movement. Mm. A lot of patients suffer night pain. A lot of patients complain of not being able to do the daily activity needed. So it is a painful disease and it is affecting the patient. So
quality of life.
Yes, that's it. So this is why most of the patients seek treatment, and this is why we offer treatment for them, because
Excellent.
it does limit their daily life. Yes.
What's the common cause from your clinical practice? And
common causes are operation by itself. So any shoulder operation will cause stiffness of the joint and a frozen shoulder. There is a lot of predisposing factors like heart disease, like heart surgery, like diabetes, rheumatological diseases will cause a frozen shoulder. Are more prone to have frozen shoulder than other populations. Okay, injury by itself. Some people will fall down and keep their shoulder in a sling for a long time. This will cause stiffness and will some degree give us a frozen shoulder.
Very interesting. Thank you, Dr. Hassan. Now we'll go for a brief report about what causes shoulder pain. To know more details about this report, stay with us, please. Don't go away.
There are a lot of causes for shoulder pain. The first thing you want to understand is that the shoulder is a very complex joint. It is what's called a ball and socket joint, meaning there is a socket, which is part of your scapula, and then you have the long arm of your arm here called the humerus, and that's the ball. So inside, underneath here, you have a mechanism of a ball and socket, which means it does allow for a fine number of degrees of movements. For instance, it can horizontally ab and adduct, it can flex and extend, and it can rotate, and it can also do them in combination. And the point of all that is that it relies heavily on the muscles and the ligaments and the soft tissue for stability. It's an unstable joint. So over time, using your arm incorrectly with reaching, with lifting, and with carrying, can lead to some strains in the muscles. Another cause of shoulder pain is the idea that because of our sitting posture and our posture in general, we tend to round our shoulders forward too much. And as a result, the structures in the front side of our shoulder tend to get shortened and stronger, and the structures on the back side of the shoulder end up getting weakened and lengthened too long during the day. And as a result, there's a poor balance. Every time we go to reach or carry or reach for something, we're going to create an imbalance in those muscles working, and we don't know it at the time, but eventually that can lead to some muscle strains, or worse, some joint pathology like degenerative changes in the joint. The other problem with the shoulder is that it does rely heavily on having the person use the arm to the fullest, meaning using all the ranges of motion that it's allowed to do. But unfortunately, our daily life doesn't require that. We tend to use it in front of us, we tend to use it down here, but we're rarely up here doing activities, and as a result, we lose some range of motion. We lose the ability to do it, and it becomes very restricted. That can then also lead to further degeneration inside the joint, and further breakdown in the need for care.
Once again, welcome back to Elixir of Life. My pleasure to welcome back Dr. Hassan Sawan, consultant orthopedic surgeon, upper extremity and orthopedic oncology consultant, talking about shoulder problems. Just we'll continue the discussion we posed on the shoulder problem, adhesive capsulitis or frozen shoulder. Now we'll move on to the next common shoulder problem, arthritis. So if you don't mind to tell us more about the symptoms of arthritis and management.
Sure. So let's speak about arthritis. Arthritis is it's a decay of the joint because of aging. This is the most common cause. So as we age, the water content of the joint decrease or change. Let's say change, but better than decrease, and it does affect the mobility and the quality of the cartilage covering the joint. So at that point, the cartilage will decay with time, and the bony contact, make it simple for our viewers, will be more. So biomechanics of the shoulder will be different. As we said, it's a very harmonious joint, so it will affect the movement to get go. Most common problems we see in shoulder actually in Saudi Arabia is related to sickle cell anemia. They have a condition called avascular necrosis of the proximal humerus that cause some issues with the joint lining itself and cause early degeneration of the joint.
Due to cut of the blood supply to the...
Yes, that's it, exactly. Commonly in Saudi Arabia because of sickle cell anemia, but it can happen due to alcohol consumption and some other causes.
Steroid like this. Okay.
Steroids, trauma, yes. The patient classically will complain about, as we said before, pain and decreased range of motion. Decreased range of motion will affect the patient usually in daily activity, reaching to his pocket, sometimes reaching to his mouth, reaching above his head, doing outreach to any extent. It will affect his movement. Shoulder is very mobile joint, as we said before, and this will affect the quality of the life of the patient. And the pain itself is a major disability for the patient. It usually happens, as we said, at night. A patient will get some relief from using non-steroidal medications and painkillers. But the best treatment in the end is usually surgical treatment.
Excellent. So, is rheumatoid arthritis can cause arthritis?
Of course. It's common to have rheumatoid joints. Some inflammatory arthritis can cause, shoulder arthritis.
So, does the age make difference? Like you see degenerative arthritis more in elderly compared to, let's say, arthritis in young?
It does happen in elderly, and usually it is degenerative arthritis, as we said, or osteoarthritis, primary osteoarthritis.
Yes.
In young patients, we see it more frequent in Saudi Arabia related to recurrent dislocations. Because every time you dislocate, you cause a scratch on the joint, let's say it like this, and every scratch will cause more scratching. So it's a vicious cycle. So the patient will have more arthritis in the end. And due to sickle cell anemia, as I said, in young patients. Yeah.
Excellent. So arthritis or degenerative arthritis more in the knee compared to the shoulder.
It is more. It's more common in the knee to the shoulder. We don't see that much of shoulder as a shoulder surgeon. That much of shoulder arthritis as compared to the knee. Our colleagues in knee, yes.
Because the weight bearing, is it the bio?
It is related to weight bearing, yes, more or less.
Very important. Now we'll go to most important question. What's the state of art therapy and research on shoulder problems?
So there's a lot of conservative treatments, advanced techniques that somebody are using, or some people are using. It's not proven until now the efficacy of it, but it's out there in the market. A lot of people are using it. Myself, I'm very restricted in using such until I have like good evidence to use. It is expensive. It does work sometimes, but we don't have solid data for it, like PRPs, and now some people are doing fat injections. And
what PRP stands for?
It's protein-rich plasma.
Excellent.
Some people using it for degenerative arthritis, for rotator cuff tears. There is a lot, and when you have a medication that is used to a lot of conditions, you know it's not very specific for any structural issues. Some patients have success. I'm happy for them, but there is more research needed to be convincing. You know, a lot of let's speak about surgery itself. Surgery, there is advance in surgery techniques. We are going more to minimal invasive, more day surgery, better pain control after surgery, better rehabilitation protocol, so patient can go early back to work. We rarely keep the patient more than 1 day in the hospital. Very rare in shoulder surgery. Most of the patients go home in the same day or after the first day. A lot of new surgical techniques, as I said, related to arthroscopy.
Excellent.
Surgeons are getting more expertise in it and doing it better. So they are performing more complex surgeries using the scope. And we have in Saudi Arabia a lot of great shoulder surgeons that are using these techniques. Other things in advance is the shoulder arthroplasty. So shoulder arthroplasty are now becoming more and more frequent, especially in North America and Europe. In Saudi Arabia, it is getting there.
So joint replacement, shoulder
joint replacement, and reverse shoulder replacement for rotator cuff tear, complex rotator cuff tear. So a normal shoulder replacement cannot be used with a rotator cuff tear, a big rotator cuff tear. So it's a different implants, but it's out there. There's a lot of implant choices, a lot of 10-year record of good result. Comparing to the knee and the hip, the shoulder joint is doing fine. So this is a good thing that's happening. For patient control, pain control is much better, and the patients are more happier.
So the most common indication for shoulder joint replacement, you mentioned rotator cuff.
So the most common issue is degenerative changes. Arthritis or degenerative joint disease. In rotator cuff tear, if we don't treat it in good, I mean, if the patient is, if the rotator cuff tear itself is old or large or massive, and the patient is old in age, usually we use something called reverse shoulder. So we reverse the ball and socket. Here is the socket and here is the ball. You reverse it. So the ball would be here and the socket would be here.
Oh, so you can show it.
So as you said, this is the normal anatomy. Our normal joint replacement, you replace the ball with the ball and the socket with the socket.
Yes.
And in the reverse shoulder, you reverse. So here will be the ball.
Yes.
And here will be the socket. This is actually trying to play on the biomechanics of the shoulder. So we don't need the rotator cuff anymore. So the deltoid will do the job for us and move the shoulder without the help of the rotator cuff.
Excellent, Dr. Hassan. Just bringing me to a very important point, the importance of physiotherapy, occupational therapy for upper extremity disorder or shoulder problems.
So I always tell my patients that God created like 16 muscles around the shoulder. If he have one or two diseased, we have another muscles to work. If really we reconditions the shoulder muscles, most of our problems, especially conservative management, will be more successful. So as we said, so dislocation can be treated with good physiotherapy. Rotator cuff problems, most of it can be treated also with physio. Frozen shoulder is treatable with physiotherapy. Compliance to the physiotherapy, we need to make the patient understand that physiotherapy is like a pharmacy prescription. So we give you a prescription to the physiotherapist, you go there, and you continue at home. It's
Excellent.
not only at the institution. They will give you the prescription or give you the
Instructions.
instruction, but you have to do it at home. You have to do it at home.
So basically, it is multidisciplinary approach. So
Yes.
you work together in harmony with physical therapists, occupational therapists,
Yes.
and they are subspecialized in upper extremity as
Yes,
well,
yes,
like
of
yours.
Yes. So there is a lot of different techniques in physio used. Maybe physiotherapists would be better than me to speak about it, but can be muscle strengthening, range of motion exercise, cold and ice compressions, shockwave, ultrasound.
Okay, excellent.
There is strapping, there is needling, there is
Excellent.
a lot of different techniques.
Very
Yes.
important.
Yeah.
I think before we conclude, we ask about important question that pop up from time to time, the role of stem cell transplant in shoulder problems.
I think this is one of the future of shoulder surgery. I hope we have good evidence in the future to support this treatment. Until now, I don't do any injections with the fat cells or stem cells for my personal reasons. I'm not convinced yet, but I think we need more research.
It's investigational for the time being.
Until now, I don't think it's a standard of care. Let's
Sure.
say it like this.
Excellent. So you didn't recommend patient if they hear about this, they go for it. They should wait for further, evidence.
There is some evidence about complications that is still also out. So it's a new modality of treatment. Patients go for these injections usually out of we have to understand the patient that he's suffering of pain and he needs somebody to help him. This is why he's trying the best he has.
Okay.
A lot of patients try to avoid surgery, but let me say that we have another modalities that it's working, and we know it's working, so we should give a chance to those modalities before going to something that we don't know about.
So, excellent. So is it true that because some patients, they think excellent surgeon or successful surgeon who always recommend for surgery? If as your surgeon you don't recommend surgery, conservative, or he is not good, can you just, let's say, correct this misconception, okay?
So let's say it like this. Surgeons love to operate. This is for sure. This is our job. But also surgeons do have the skills and the knowledge to know that when the patient needs surgery and when he doesn't. Everything have a positive and negative.
Sure. Pros and cons.
Unwanted surgery is something that can cause problems for the patient and the surgeon in the future. So we usually balance the situation, and with discussing with the patient and let him understand what's the positive and negatives.
Risk and benefit ratio.
Yes, and he can decide for himself, and we can offer the help usually.
Excellent, great. Before we conclude, Dr. Hassan, I would like you to give us take-home messages from your excellent, let's say, talk.
Let's say one thing for advice for my patients, that really physiotherapy is, I'm an advocate for physio, but it does really work. It does really work.
Magic,
Yes.
okay.
So it does work. A lot of patients are happy with it. You avoid a lot of unwanted admissions and unwanted procedures. Physiotherapy need the patient to work hard at home. So this is the only limitation that the patient have usually, because most of us don't want to follow instructions, and we want the easy access. But really, physiotherapy is a good way of treatment. This is the first thing. Second thing, we need to believe in our surgeons that we have in Saudi Arabia, that they are experts in what they are doing. And we offer the patients the best treatments that we have. And when we recommend surgery, usually it is for the benefit of the patient. And we, in Saudi Arabia, we reached the degree that we are, compared to others, our peers in the world, we are in a good position.
Excellent. Dr. Hassan, thank you for such a wealthy, insightful and fruitful discussion. This joint is very complex. You made it easy and you encoded its complexity.
Thank you so much.
Thank you, Dr. Hassan. I appreciate for being with us.
Thank you.
and would like to seeing you again our program.
Inshallah. Thank you so
Okay.
much.
And now we are coming to the next segment, health benefit. Watch more details about this report. Stay with us. Once again, welcome back to Elixir of Life. Now we are coming to the end of our program. Thank you for viewing our program, and I wish you found it useful and informative. Before I conclude, I would like to thank our great team, starting by Mohammed Al-Qasim is sound, Mohammed Al-Amshi, Deco, Salim Al-Arabi, cameraman, Abdul Majid Al-Shimmari, lighting, Rihab Khalitit, preparation team, and our director, Mohammed Arar, and myself, Dr. Mohammed Alsheef. I wish you enjoyed watching our episode and looking forward to seeing you. And until next week, we wish you a pleasant week ahead. Assalamu alaikum wa rahmatullahi wa barakatuh. Goodbye.